So, go. Hi, I'm Gene Ransom with MedChi, and I've got Jessica here from CRISP, and we have Nathan from PACES. And this is actually the first in a series of meetings we're going to be doing to explain what the crosswalk is going to look like going from Prometheus to PACES. So I'm going to go ahead and turn it over to Jessica, and Jessica will probably turn it over to Nate. So go ahead, Jessica.
Yeah, basically. But essentially, what we wanted to do was we shared sort of at a high level some of the great things that Pieces has to offer, including transparency, the ability for us to push out data more frequently on a monthly basis versus quarterly that we're doing right now. However, it is a new grouper, so we would expect there to be some differences. The intention really is before we fully roll out the PACES methodology is to be sort of upfront about what at a high level these changes look like. Overall, I'll have to say, I think some of the biggest differences that we see is we're moving from a grouper that has about 100 episodes to a grouper that has about 1,000. So there's some specificity in the PACES episodes that were not available in the Prometheus episodes. And we'll go into some of the details of the availability to have additional episodes and what that may mean. And then I think there's also specifically for GI, there's some standard windows in the pre and post trigger period that vary pretty significantly from Prometheus. So I think that's really also a point of discussion to get stakeholder feedback. Overall, we want to maybe avoid a lot of customization, but this seems to be a pretty good use case to actually make those changes and not have such a significant jump in the total episode. So with that, I'm going to turn it over to Nate Hegberg. He is with Hmetrics and does a lot of the analytical support for the state and for CRISP. So thank you, Nate, and I'll hand it over to you.
All right. And Jessica, you can see my screen. Everything looks good.
Yes, I can. Thanks.
Great. So jumping on in then, so what we've essentially done is over the course of the past 6 to 8 months now, the HSCRC has been running a lot of analytics and a lot of simulations on both the data that we have from the Prometheus grouper across the entire state and for the known participants for performance year 1. And then running similar analyses on PACES, as Jessica said, really trying to understand where the differences are. And just kind of kicking the tires on the grouper to make sure that the state's comfortable with the logic and the approach before presenting it to you all. So some of this was presented slightly differently at the general EQIP subgroup meeting. So some of you may have seen some of this content, but did just want to start off with kind of the opening, analysis. We did run kind of a what if scenario on the PACES data, looking at the performance year 1 EQIP entities and episode selections. And across the board, that simulation generated pretty similar results as the actual results that we got under Prometheus. So writ large, total savings for the program is roughly the same. And perhaps more importantly, the EQIP entities that we saw succeed or demonstrate savings under the Prometheus grouper were also the same entities that were generating savings to roughly the same degree under PACES. So did want to talk about that. And again, there's a number of different ways that we can kind of cut the data. So the numbers here are all just based on these analyses and simulations. And ultimately, at the end, we'll have a couple of discussion slides where I'll turn it back to Krista and Jessica, where we just want to get input, thoughts, reactions, so that we can make sure that the transition is as smooth as possible, and we're preparing the materials that are going to help make that transition easy, assuming that it goes forward. So at the EQIP subgroup meeting, we kind of talked about episodes as a whole. Here, obviously, we'll focus on GI episodes. And I think for this group, perhaps the most relevant piece of information or differentiation between the groupers is, as Jessica said, the level of specificity. The Prometheus grouper includes a pretty broad range of episodes under a lot of their, especially procedural episodes, and PACES does tend to break those out a little bit more. And we're looking at different ways to facilitate enrollment in the new episodes so that EQIP entities have roughly a similar experience to their current enrollment if that's desirable, or understand how their enrollment would change if that got modified with different episode selections under the new grouper. And the colonoscopy episode is a good example of this. And again, the PACES Institute has been really great to work with. They've been open to feedback. We've already gotten some feedback regarding this that we've engaged with them on. So again, any input is always welcome. But the current PACES definition we're working with, the colonoscopy episode is really focused on just therapeutic and diagnostic colonoscopies as opposed to screening, which accounts for the difference in volume and target price with those screening cases broken out. So again, just want to be able to highlight these types of differentiation. Episode parameters, as Jessica mentioned, will also come into it. We'll get to that in just a second. But just wanted to kind of encapsulate that as probably the main discussion point and place that we're going to be looking for feedback and to provide additional guidance. So if we look at the performance year one enrollment and kind of break out the episodes, you can see on the left here what the total volume and aggregate target price, again, if we average across the entire state, is for the 4 GI episodes that were available, and on the right, how that maps out to PACES. Now, again, the main differentiation here is you will see that where Prometheus might trigger both a colonoscopy episode and an upper GI endoscopy and split cost kind of evenly between them. Here we do have a third combination episode that accounts for those. And the hope here is that this additional level of differentiation creates a cleaner resource and kind of clinical profile for each of these. Now, obviously, we're not clinicians and we're interested in kind of feedback on how best to address these. But the, again, philosophy behind the PACES grouper is they want to create roughly equivalent clinical and financial bundles. And to do that, they've introduced this, again, additional level of aggregation into the data. Now, I think the main benefits that we've seen to PACES are the increased transparency around episode definitions and how exactly the grouper works, as well as a lot greater flexibility in how we can use the grouper, which means we can get data out sooner and more frequently. But we want to make sure that the episode definitions themselves are also substantively equivalent, or that we can work with all of the participants to facilitate that transition. So we do want to make this type of data available. And again, you can see kind of how the cost profile and episode volume varies across the different episodes. And when we get into discussion, happy to talk a little bit more about that, as well as show you an example of the definition workbooks that we have and can make available for the different PACES episode definitions. Now, as Jessica alluded to earlier, I think one of the things that is particularly important to review for some of these episodes is the look back and look forward period for each of the episodes. For colorectal resection and gallbladder, along with a lot of the other episodes that are more kind of standard procedural episodes, the episode construction by default is fairly similar. It is for some of the other procedures like endoscopies, colonoscopies, where we do see this difference. So these parameters are configurable, so we do have the option to set these differently if the state, as a program policy decision, wants to. But again, we need to be careful, especially during this first year of transition, how much customization we do, just to make sure that we're getting the full benefits of the grouper and only making adjustments where it's really needed to make sure that we're meeting the goals of the program and kind of the goals of all of the participants who are enrolling. We've also created these kind of breakdown charts that we can share that kind of go through and show how the episode volumes differ. This is just an example for colonoscopy. And the main things I do want to highlight when we're looking at differences between the two systems is the fact that these breakdown charts use those default parameters. So you can see that we do have a lot of episodes which are dropping out because of that longer episode period. Now, EQIP is based on episode end date. So if you have an episode start during a performance period but end after, that would get dropped. But then on the other hand, we are picking up more episodes that are starting prior to but ending during the performance period as well. And again, as we go through additional iterations of this analysis and work with you all, we'll update these. So for example, if we did change the episode length to be shorter, this breakdown chart would change to reflect the inclusion and exclusion based on those change parameters. And again, we can circulate those. The second piece I wanted to highlight again is that a lot of these episodes that contribute to the apparent drop in volume are picked up in these other categories. Almost 3,000, screening colonoscopies, as well as a lot of those joint episodes that are getting picked up in the combination episode category. And similarly, we've generated this for all of the different episode categories. We can go through this, but just kind of same breakdown of how the volume differs and why for each of those cases. So essentially, our next steps here are to make those PACES episode playbooks that I'll show in just a second available for everyone to review. We're going to have continuing meetings with the other specialty societies like this one to kind of go through specific clinical domains and get feedback. And then we essentially have to finish doing our due diligence on both the policies and any changes that we need to make to policy to facilitate the transition. We'll also be developing what we call transition guides that help to communicate and explain if different episode selections are needed to mirror current enrollment under the new grouper. We'll lay that out really clearly, so that's not extra homework that participants need to do when they're enrolling. So with that, again, trying to save most of our time here for questions and discussion. Again, I'll hand it back to Krista and Jessica, but I think these were kind of the main areas that we wanted to focus on, just kind of thoughts on the breakout of the different PACES episode categories, on those different parameters, and then in particular, just what additional information the HSCRC can provide that's going to be helpful both in understanding this transition and the impact and also communicating it to any physicians in your entity or other folks who need to be aware. Anything else, Krista, Jessica, that I didn't touch on that you want to make sure that we get back to?
I don't think so, just that we will make the playbook available for you all to see some of the codes and stuff in more detail, hopefully within the next week or so. But yeah, as I think Nate mentioned, really the intention here was to say if we use the default of everything with PACES, this is what it looks like. But again, want to have that open conversation to see if there's ways that we could make this more conducive with the transition.
And thanks, Nate. I don't have anything to add to that.
And to the question in the chat, Jessica, I know the slides and recording will be available. Are those going to be available through the HSCRC or MedKai's site?
Both. So we like to put them up on MedKai's. MedKai probably be first or the quickest, and then also on Chris' website. But yes.
So I guess the question I have is are we talking about making the PACES episodes look more like Prometheus, or are we planning on keeping the PACES episodes kind of the way they are?
So I think our goal is to use the default PACES ones. I think particularly here where the initial feedback, I think, would be to change the those episode lengths. That would probably be a tweak or a customization that would make a lot of sense. I don't believe our intention is to go through and validate all the CPT codes in each one of these. I just don't think that that's probably worth our time. And obviously they've been at the state that they are now because PACES feels that they have been clinically vetted. But I also want to ensure that there's a understanding that, PACES may look, when you get the results from PACES, it's going to look slightly different because you're going to have, a 1-to-3 ratio within these episodes or sort of things like that. Another piece of feedback that we've received is, right now the default does not include screening colonoscopies, and that does account for sort of a big drop. Does that make sense? I think, as Nate mentioned, PACES is very open to working together. And we want to make that decision with your all's input, since, we are not clinicians and, GI experts by all means.
Yep. And to the question in the chat about trigger codes being the same, they will be different. I mean, a lot of them are substantively similar. So I know ortho a little bit better than GI, but like the trigger codes for a knee arthroscopy are, basically the trigger codes for a knee arthroscopy. And really where the differences come down is to how they break things out. So again, this is what the kind of default workbook, definition workbook looks like. It has the basic parameters, your trigger codes, and then any additional relevant tie-in information. So as Jessica mentioned, right now, these trigger codes for the colonoscopy episode are specifically for diagnostic and treatment ones. Those G codes for whether they're high risk or normal risk screening aren't included here. But again, PACES has been open to feedback in terms of deciding, well, does it make sense to roll these in here or keep them as a separate episode? And again, even if they are a separate episode, that would still be available for enrollment. And I think that piece of how do we define, what episodes a given EQIP entity wants to enroll in to make sure they understand which of the episodes they would have picked up under Prometheus, they'll pick up under these new definitions are. But you will see some refinements. One of the other reasons that we are moving to PACES is it does seem like they are a bit more proactive about updating and maintaining the code lists. So we might actually see some differentiation just because as the practice of medicine evolves and as the coding for different procedures evolves, the system will get those updates as they occur as well.
Yeah, I think Nate makes a good example. I'm Mark. Sports physician, orthopedist, have been helping out with the CRISP team and MedChi on some of these episodes, and I can say that the PACES episodes are going to be more inclusive and have more updates because the Prometheus episodes weren't updated as frequently, and so you might see an additional CPT code that changed from 3 to 4 years ago, but I would say the trigger codes are going to be very similar.
Yeah, the one thing though, it does seem in GI losing that screening trigger does make a difference. So is that something that, I'd like to hear if any of the GIs on the call have thoughts on that. And then the other thing I was really wondering was, and Grace, will let you go in one second. Are we going to do a little bit of a crosswalk with real numbers for some of the bigger groups and hospitals to make sure we don't have any other incredible outliers? So can we take some of the bigger practices and look at what their year one results were, compare it to what would happen under Prometheus? And I know we did some of that on an aggregate basis, but can we do that on a more granular basis, maybe for some of the hospital groups and maybe for some of the private practices?
Yeah, Jane, I think that's a good piece of feedback. One of the things that has been brought up, and we just need to figure out exactly the mechanism and how, but potentially after we're done sort of all of these series of changes, is to give our existing EQIP entities sort of a one-page summary sheet of what that change would be now that they kind of understand the details between them, knowing that we have some groups that are one specialty, some are multi-specialty, so there could be multiple factors that are influencing the change. But I think that's a really good piece of feedback, and we definitely will do some version of it. Like I said, we got to kind of figure out timing and what it'll look like, but certainly want to be able to be more transparent at the individual entity level.
Right. Jean, I that's exactly what I was going to ask, but I'm a gastroenterologist and I'm part of multi-specialty. The two codes that you guys brought up under Prometheus, also under PACES, is gallbladder surgery and colorectal resection. Gastroenterologists do not do those procedures. So I'm not sure how we're attributed those. That's number one. And the second part is, as Jean pointed out, we actually had a meeting yesterday with the preliminary data from 2000. I think that was our previous. We missed the year one, so we joined year two. So we had baseline data that came out. So we had an in-depth, look into what codes are triggering, where we stand, etc. And we were looking at colonoscopy. One of the things that really affected us was the rate of atrial fibrillation, which is one of the codes that somehow, I don't know how in the world it got in, but I'm hesitating because I think we have a great idea, great plan, but some of the codes, like for example, if a patient comes in with AFib, those patients do not get colonoscopy. They're sent somewhere else, but that's attributed to me. And we are going to go in depth because we do have CRISP available to see how that happens. So some of the codes that are affecting us, I'm really questioning why is that even affecting us? Likewise, if you take out the screening colonoscopy, which is bread and butter, I'm not sure how that's going to affect us. And if you have year one results, it'll be great to look back and see it's really tough to work with something where you don't have the data. We've gone through a whole year. We still have no idea how we're doing. How can we improve for next year when we don't even know where we stand? So having data come to us more frequently will help us improve, I think.
Yes, I certainly can touch on a couple of those points. A lot of the aggregate data that we were doing actually was off of performance year one data, since we do know that those are real numbers. Everything has claims have run out and everything like that. I think that very first slide that Nate had at the very aggregate level is, again, based off a performance year. So we do feel that those numbers are real. Again, the variation of how that impacts at the individual entity level could change. And then the other thing I want to touch on is both for PACES and Prometheus, the definitions are very literal when it comes to the claim. So it's looking for a specific CPT code with a diagnosis code to essentially open the claim or open the episode. However, of course, because it does use a somewhat relevant cost model, not a true total cost of care model, you are going to see some other things that may be directly related to the procedure or not. And certainly those are things that potentially are opportunities or some noise that's associated within it. I'd be happy if Grace, if you or your analyst team wants to reach out, we can maybe go into that a little detail to kind of figure out what's going on there. But certainly the intention of all these episodes, again, are really dependent on those trigger codes. Again, there's obviously comorbidities and none of them are super simple, and there's a lot going into there. But yeah, it's something that we can definitely look at, especially since you all, of course, are only working off of 6 months of performance data right now, given the timing of things. So yeah,
Grace,
absolutely.
can I also, and I'm sorry to keep calling you Grace because I realize you're a physician, but I don't know
That's
your
okay.
last name.
Yeah, I forgot to put my last name.
Anyway, let me ask this question: is multi-specialty, do they have one EQIP entity, or did you break it up based on the bundles and by the specialties? Because I know you guys have, you have everything in multi-specialty.
Yeah.
Do you know how that was set up?
Yeah, so we actually had a long discussion with Jessica before we set up, and before your year one data came, we didn't realize this, so we put it under one entity. And then Jessica, I think you spoke with Andy and told us that
yes.
of the two, you guys told us one group did it together, one big group did it separately. So this year two, we separated amongst gastroenterology, orthopedic, cardiology. So we did separated that way, in case one group does well, it's not going to wash out the other group. And the
Right,
data
and also
that
it helps you guys from a clinical management point of view get better
Mm.
quality. It's not really just the gaming the system. It's really about trying to be successful around each service line. So, well, maybe what we can do is maybe Jessica and I can set up a meeting with you guys and have a discussion and see if we can't be helpful and work together on it.
That'd be wonderful. Yeah, because we
If you
actually
send
had
me your
different
contact in the
specialties.
chat, I'll work with you and Jessica, and we can find the appropriate people and have a discussion specific to you, given the fact you guys don't have year one results. Okay.
That'd be great. Thanks, Gina.
Okay. Anybody else have any questions or comments?
Amina, I see your hand is up.
Hi, thanks so much for this, for the presentation and for getting the group together. Just a quick question, sort of to Grace's point. So we're also seeing, right, like AFib pop to the top of our list as potentially avoidable complications for a lot of our episodes. And I was just wondering generally, what is your sense of how the potentially avoidable complications measure up between the Prometheus grouper and the PACES groupers? Do you think that there's Like it was more comprehensive under Prometheus, less comprehensive under Paces, or do you have a general sense of that?
Nate, I'm going to ask you, is there an equivalent of the PAUs in Paces, or is that strictly a Prometheus definition?
Yeah, so the definition itself is specific to Prometheus, and unfortunately, again, part of the motivation for evaluating this change is I don't know a lot about the internals of the Prometheus engine. We're just not given access to that full logic. So the way that Paces is intended to work is a little bit less prescriptive. And so instead of saying something is a potentially avoidable complication or something like that, it simply establishes associations between conditions and episodes based on the procedure and diagnosis codes that are part of the episode definition. I believe Paces, as a general rule, is more targeted than Prometheus is in that. You'll see. So again, I don't know the details of exactly why, AFib in that example got pulled in. We can definitely try and figure it out as best we can for Prometheus, but I think you'd be less likely to see that under Paces. And if it did occur, we'd be able to provide a more clear example of explanation of here's why that association was established. And one of the things that the HSCRC is working through right now is the extent to which we leverage those Paces episode associations to establish the target price and episode responsibility. If we pull all of the associations in, that does give us the results that are closest to Prometheus, and it does add some additional cost and potential savings opportunities to the episodes. But I think, especially hearing questions like this, it's something we can spend more time on, kind of digging into how many, of these associations appear intuitive and make sense versus which ones would we question and say, okay, why exactly did that seemingly unrelated condition get pulled in? And we can make a note to follow up on that for these episodes in particular.
Got it. That's really helpful. Thank you. And to the extent we can help you look into that, we're happy to.
Right. Yeah, no, examples are always helpful, especially since you guys know your data better than we do. Anytime that I can have somebody point me to where in, the haystack the needle is, it definitely cuts down on the amount of work that we're doing when we're working with the entire data set as a whole.
Sure. Thanks so much.
Another question. It came up yesterday. So some of my team members were asking, are you guys taking into account those complicated patients, for example, doing a polypectomy on a 50-year-old with no medical issues versus somebody who's diabetic, cardiovascular, peripheral vascular disease? Complications of those are much higher. Does the data take that into account?
So the way that we kind of view risk is really in the setting of the target price. So essentially, since you are, or the group, the entity needs to sort of beat their own historical data to be in a position where they share some incentives, the risk is sort of built in, meaning the population that you all saw in 2019 we have some high and some low acuity in there, and that's really impacts the target price. Obviously, we know that there could be some major significant changes in that and things like that, but essentially that's where the risk is baked in. So the variability that you're seeing, a really complicated, many comorbidities, that type of patient versus ones that may be more straightforward, the distribution of that, if it mirrors sort of similar to the distribution that you saw in 2019, you're going to have that already built into your target price. Since you're only trying to beat yourself, you're not trying to beat, let's say, a state average.
Yep. And then just adding on that, right now, the default policy for Prometheus that's present in EQIP is that the top and bottom, 5% of cases get truncated. So if you do have a small number of really high cost outliers, those are going to get filtered out. But within those bounds, if an episode triggers and isn't otherwise excluded, to Jessica's point, they will all get pulled into the pool. But there is that extreme outlier truncation. And as of right now, correct me if I'm wrong, Krista, but I believe the thought is that 5% kind of threshold will remain at, as we transition into Paces, and we'll continue to, keep an eye on it to make sure that it is appropriately, adjusting for those outliers.
Yes, that's correct, Nate.
I had one other point I wanted to make. Paces, I believe, has some unfinished GI episodes, if I recall correctly from an earlier meeting. So one of the other things, and I don't think this is something that necessarily needs to be done today, the urgency is around making sure the bundles that we have get corrected the way we want them. But I would just put it on everyone's radar that if there's an interest in looking at what else is out there or developing something new or working around those other bundles, we would love to have a couple volunteer physicians to work with MedKai and maybe Nathan and Jessica and I to just kind of see what other opportunities are there for additional bundles. Again, I think it would be really difficult to get things together and done for 25, but I'm just putting it on the radar. If one of you is really excited or has a good idea, please let us know.
I will add that there are also episodes that PACES considers fully vetted GI episodes. So they are essentially ready to go, easily deployable in sort of the GI general surgery world. If there is interest in sort of seeing those, because those would require really more stakeholder feedback saying, hey, we want to add these versus the lift of vetting and sort of clarifying
I didn't realize we had some fully vetted ones. That's great. Maybe what we could do, if we don't mind, maybe we could just send a list of which ones they are to the group and see if anybody, if it excites anybody, you know, if that's all right. If we can create more opportunity, that's always good for the program, you know. Does anybody else have any questions?
That's one of the questions. Grace again. So where do you think we're headed in the long run with all this data and this cost savings, et cetera? Is Medicare trying to bundle pay us? Obviously, you guys don't make the decision. So I'm just looking ahead, because a lot of the questions I get from our specialists, and some people are not participating, is they don't want Medicare tracking where I stand among others. So they're saying, I don't want to be targeted that way. And then they're saying, as a special, it's very different as an internist. For internists, they're saving MSSP, MD, PCP. By preventing them going from the ER, they're saving a lot of money, makes a lot of sense. For specialists, the buck stops here. So for example, if my internist calls me and says, I have a patient with melanoma, they have a choice of sending them to the ER or me taking that patient in my office, doing an unsedated EGD in the office, doing labs and do all that kinds of stuff. But if I'm part of this program, that cost will go up. For me to undertake a GI bleed as an outpatient is probably more costly. I'll be triggering a lot of points along the line versus just sending them to the ER and having a GI, hospital GI take care of it. So as we are participating, I think this is the way to go. Yes, value-based medicine. But as a specialist, I'm sort of thinking long-term, where is Medicare and the government trying to go with this program?
Yeah,
You guys may not know this.
I can explain this. First of all, I think this is completely separate from the state of Maryland, the specialty models, but it's, the models exist in Maryland is a very important step. But I was with some of the CMMI directors. I think the first thing that you should know is completely separate from Maryland. There are companies out there, and there's several of them, that have access to Medicare data and commercial payer data, and payers and primary care doctors are using this already today. So whether your Care Journey or Bamboo Health, they're looking at the variation of cost of care and specialists. And I've seen some of the things, and it is concerning because they don't know who's low cost versus a high cost specialist and low cost versus high quality, and it can be very challenging. But that data is fed to a lot of primary care physicians separate from the model. Secondly, I do think we're going to be moving in the direction towards subcapitated episodes with multiple different types of episodes in the future that will break down into acute, chronic, and procedural episodes. But I think, this is all separate from the EQIP model in the state of Maryland. I think the importance of the EQIP model in the state of Maryland is this is an opportunity for independent physicians to really try to coordinate care and look at something and be involved in the value-based care model. I know Jessica and Jean have put a lot of work and effort in trying to be ahead of the game, which I think is really, really important.
And just the other thing too that's going on, and it was funny when you made your comment about looking ahead. CMMI has announced a major program called Ahead to kind of really move more states towards value-based care. And I think we will be applying as a state. I mean, official, I guess that decision hasn't officially been made, but it all has been made. So I think you're going to see more and more of a move as we kind of stair step towards more value-based care. And what we need to do is think about how do we adjust for that so we're successful. And I will say this, and I obviously I run the physician association in Maryland, right? In my mind, I think this is a good thing generally, because if we go to value-based care, physicians make the decisions on what services are purchased and used. In fact, I've seen studies that show that every dollar that's spent, we're deciding where 85 cents of it goes. If we decide where 85 cents of it goes and we only receive 12 cents of the dollar, there's a lot of room for us to do better generally. And I understand your point that it can be harder for certain specialists, and we have to figure that out. But generally, this puts us back in the center of healthcare, which some would argue, a lot of my members would argue that right now insurance companies are making all the decisions and other people are making all the decisions. So if we can go to a system where we're focused on the patient and deciding where stuff goes, that should be a win for physicians. And that's why MedChi has been putting so much energy and effort into trying to make this stuff work right and make it physician centered. So that's kind of our perspective on why we're doing all this. And frankly, I've been working with the HSCRC folks and Chris from the very, very beginning of this program and also NDPCP. And I think those are both really good programs for physicians. So, and this is just a continuation of that work. So that's kind of the vision, at least from our perspective.
No, I agree. Actually, I've seen care journey data also, all that information that we looked into. And there's a lot of data, but I don't think they know how to process it. So with the with the PACEs, hopefully the doctors will have a little control of have an input on what's important, because later on when they assess the data, hopefully they won't be putting AFibs and contributing to the GI doctors as a complication issues.
Yeah.
Okay. Do we have any other questions from anybody? All right, well, that was a rather efficient meeting. So anyway, we will get the recording up. I'll try to get it up today. If anybody is urgent to see it, I will try to get it up on my YouTube channel today. It will go up in the other places as quickly as possible. And again, if anybody has any questions, they can always reach out to Jessica or myself, and we're happy to help. Anything else, Jessica or Nate?
No, that's it. Just a plug for next week, next Friday, we're doing a similar one of these. It's focused on the orthopedic episodes. So if you didn't get an invite, reach out to us. We'll make sure it's forwarded your way.
If you're interested. Yeah, the orthopedic crosswalk was a little closer. Anyway. All right, everybody have a great day.